I am going to talk on recent advances in collagen cross-linking. Recently, there have been a lot of advancements in cross-linking, like accelerated cross-linking, pulse cross-linking, transepithelial cross-linking, C3R in thin cornea, C3R with low vision corrections, and also PAC CXL for management of infectious keratitis. The main problem with Dresden protocol is time. So it will take almost 30 minutes to finish the procedure. Sometimes what happens, these patients will be very uncomfortable. And so I have seen in my cases, in between, they sometimes get up and they bring their hands and touch the console and all. That is the main concern, because a drape is put, they are looking at the light, and almost 30 minutes they have to look at the light. So this is the concern with Dresden protocol. To overcome this limitation, the accelerated CTR has been proposed, and it is based on Bunsen and Roscoe law of reciprocity. So what it says is, effect of photochemical reaction is directly proportional to the total irradiation dose. Suppose there is high irradiation for a shorter period and lower irradiation for a longer period, the effect will be same. So whatever effect we get in Dresden protocol, same effect we can get in a accelerated protocol. See, in a standard protocol, our aim is to get a total fluence of 5.4 millijoule per centimeter square. The same can be achieved by altering the time and energy. So if you irradiate for 3 minutes of a 30 energy, 5 minutes of 18 energy, or 10 minutes for 9 energy, we'll get the same fluence. So the cross-linking, whatever the irradiation we do, will be same. So that is taken advantage in a accelerated cross-linking. So whether these accelerated cross-linkings are as effective of Dresden protocol. So this is the study. They have done a meta-analysis. This is published in Octa of Ophthalmologica in 2018. They compared the standard C3R with the accelerated C3R. And they included around 22 studies, and 1,158 eyes were included. 577, they underwent a standard protocol, and 581 underwent accelerated protocol, almost same numbers. What they found out was, in a standard protocol, there was little bit more depth in demarcation line. And in accelerated protocol, it was better in thinner corneas. And both the procedures provided equal results in strengthening of the cornea. So the purpose was achieved in both the protocols. Now there are so many accelerated protocols. Which one you have to choose? So when the accelerated protocols came into practice, many people started doing all type of protocols. 3 minutes acha hai. So 3 minutes they used to do immediate. So 3 minutes patient will be happy, and they used to do 3 minutes and send off. So they compared, when the studies started coming, the 30 minutes radiation for of 9 energy, it outperformed other all accelerated protocols in terms of corneal stability, improvement in visual acuity, keratometric values on corneal stability. Most of the surgeons, they prefer this protocol for accelerated protocol. As earlier Dr. Manisha told, to have a very good cross-linking, we should have 3 important components. One is ultraviolet A rays, riboflavin, and very important is oxygen. See, in accelerated protocol, what happens? The rays will be coming continuously and very fast. So what happens? At the level of cornea, the oxygen concentration will be reduced. So that would lead to the ineffective cross-linking. To overcome this, the pulse C3R has been proposed. So what happens in here, the irradiation won't come in a single beam. So it will come in a pulse way. So like we get in a pulsed phaco, no? Like that, it will come in a 1 second on, 1 second off. So in the off time, there will be more availability of oxygen. In that way, The C3R also has been, can be done, and also there will be availability of oxygen. So this shows more cross-linking. This is a study to compare the pulse C3R with a normal accelerated C3R. So what they found out, the demarcation line was better in pulse C3R than in a accelerator protocol. Demarcation line is the which we always look for after C3R. That is the line which differentiate between the cross-link cornea to the normal cornea. It has to be at least 150 to 200 to tell that cross-linking has been done effectively. And here, the pulse C3R showed more depth of demarcation line. Although this pulse cross-linking showing promising results, we exactly don't know how much pulse to adjust. Whether 1 second on, 1 second off, or whether we should do a 2 second on and 1 second on. It needs to be evaluated, and more studies are required. And in a standard C3R, what you do is we remove the epithelium. So what happens? This will lead to the risk for infection and post-operative discomfort, and it goes to the less safety profile, because we usually do it in younger patients. Sometimes in pediatric patients, we scrape the epithelium and put them in bandage contact lens. So there are chances of infection, as told by Dr. Anand. And there can also be enhanced riboflavin penetration in the cornea, which can lead to other damages in the endothelium or lens. So to overcome this, whether we can do C3R in an intact epithelium. The corneal epithelium is stratified with the tight junctions. So that leads to barrier for riboflavin absorption. So whether we can loosen these junctions, that can be achieved with some drugs like EDTA, BAC, or Tramadol. So when you apply it before the C3R, this loosens the epithelial cells, so makes the riboflavin to enter into the stroma more easily. So we can do a C3R actually in a intact epithelium. Another method is iontophoresis. So here we are not going to do any epithelial scraping and not going to do any chemicals here. This is a device which is kept on the eye, and there are some electrodes which are kept on the eyebrow and also the lids. It will create some electrical gradient, because when it creates the electric gradient, the negatively charged and hydrophilic riboflavin moves across the lipophilic corneal epithelium. So it goes inside the intact epithelium and soak the stroma. So thereby you can do the C3R. But it needs all these machines, and it is undergoing all the investigations, and you have to receive a standard device to do iontophoresis. See, in Dresden protocol, they mandated 400 microns is the minimum corneal thickness is required for a C3R. So what about the corneas which have the thickness of 460, 470, 490, 360, 380 or 390, whether we can do a C3R for them? Yes, we can do a C3R to them by utilizing these methods. That is using a hypoosmolar C3R. So it contains a riboflavin with sodium chloride. When you apply this, because of sodium chloride, the stroma will swell up. It almost becomes a double. So then you apply the is it as it we are you are increase the thickness of the cornea. Then safely we can do the C3R. And this is the most commonly performed C3R for thin corneas. There are other methods also we can do in a thin corneas, like customized epithelial debridement. Here, what we do is, we do the epithelium scraping, and leave an island of epithelium on the thinned area of the cornea where there is cone is there, and do a C3R, so that the thinnest area is where the riboflavin can enter more into the cornea and cause other adverse effects. So that is left behind, and then a C3R. And we also can use a lenticule. You do a smile procedure in myopic smile procedure, and lenticule is placed on the corneal apex, and then the riboflavin is applied. So what happens? It is a natural cornea. So what happens? It will augment the corneal stroma. It will augment the corneal thickness. So then we can do a C3R. In the same way, we can also use riboflavin soaked soft contact lenses, which can be kept on the cornea, and the C3R can be done. Altogether, what is here? We are trying to increase the corneal thickness and doing the C3R to have a safer effect. For the refractive surgeon, the post-operative ectasia is still an enigma. Even if you do a lot of investigation, pre-operative investigations, use a lot of gadgets, apply so many formulas are available now, there is a risk score is there. Even though in some cases we get a post-operative ectasia. So in such cases, we can combine this C3R, like in high refractive errors, doubtful topographies, and in thin corneas. What we do is, we do a refractive procedure, and same time we do a C3R. So it can be combined with LASIK, it can be combined with PRK, or it can be combined with SMILE. These are called as extra procedures. So you have to remember, these are called extra. PRK extra, LASIK extra, all SMILE extra. Extra is what? Extra is cross-linking. So basically, you correct the refractive error by laser wave correction, then freeze that cornea by doing C3R, so that it won't modify afterwards. This is a study published in IGO, Indian study in 2020. They included 1,512 eyes which were all high risk for post-operative ectasia, and they did all PRK extra, LASIK extra, SMILE extra, depending on the corneal thickness and topography. What they found out was, refractive surgery and simultaneous C3R is generally safe and delivers comparable results in terms of visual and refractive outcome than refractive surgery alone. So doubtful cases, we can combine C3R. And this term you have to remember, C3R plus. C3R extra is different and C3R plus is different. Here basically this was a term coined by Dr. Camionis in 2011, and basically what we do, we treat the keratoconus with C3R and then refractive error with other procedure. So most commonly performed is PRK with C3R. It has to be done topo-guided, and there are some limitations for this procedure. We cannot go beyond 50 microns of depth of ablation, and post-operative corneal thickness should be 400. So if the post-operative corneal thickness reduces than the 400 after refractive surgery, these keratoconus patients are not fit for the PRK extra. And here the aim is to correct the corneal irregularity, not to correct full refractive error. So when you correct the irregularity of the cornea, post-operatively they accept the contact lens or spectacles better, because it reduces some amount of aberrations also, and cornea is regular. And we can also use intracorneal rig segments with C3R. It can be done in same sitting. First ICRS implantation and C3R. It can be done in epithelial off, epithelial on. Here riboflavin can be introduced through the corneal channels. We make a corneal channels for the introduction of ring segments. The same way, in the same channels, we put the riboflavin, and we can also create the intrastromal pockets and do the C3R. Phakic IOL with C3R. First you do a C3R, stabilize the cornea, and after 1 year, see whether the cornea is stabilized or not. Then we can go ahead with the implantation of phakic IOLs like ICL, IPCL, all those things. The drawback here is corneal irregularities are not corrected. So there will be some amount of aberration depending on the keratoconus. And only the spectacle power is corrected, not the whole, all the aberrations are there. And if the cylinder is high, that is a limiting factor, because the phakic IOLs maximum cylindrical power we get is 6 diopters. So the cylindrical power is more than 6 diopters, so it may not be applicable. And this can also be, C3R can also be used for infectious keratitis, because when it is photoactivated, there will be oxygen species which subsequently act on the microbes. So this has shown us some promising results. This is one study where recently published. They did C3R for infectious keratitis. It can be alternative to antimicrobial drugs. So you can do it as a first line in treatment. The only drawback here is we cannot do it a very well established keratoconus. Infectious keratitis. It can be done in an early infectious keratitis or a moderate case of infectious keratitis. This is the one example where the C3R alone has been done. In a first case, there is infectious keratitis, and after 7 days, it starts healing, and at the end of 28 days, it completely healed. And the second image also shows the infectious keratitis. After C3R, it's completely healed. So here, they have done only the C3R for the infectious keratitis, which is mild case. Thank you for patience hearing. So if there are any questions to any speakers, because we have another 10 minutes, we can take the question. Yes.
Sir, for plus procedure, how long do you have to wait between the procedures? For plus CXL, how long do you have to wait after doing CXL for?
We have to be sure if you are doing plus the phakic IOL, at least 1 year we have to wait.
For the PRK, trans PRK?
See, PRK can be combined with C3R, because only thing is the limiting factor is we can ablate only 50 microns. But if you do C3R now and do a PRK later, what happens? That is not advisable. Why means whatever the cross-linking has been done, that cornea will be ablated later.
Okay. Yeah.
So the cross-linking effect will come down.
Okay, sir. So if we have a 440 micron thick cornea and we are ablating 50 microns, so the effective residual thickness will be 390. So is it advisable to do C3R for that patient with the PRK?
The 430 depends on the refractive error. So the post-operatively, the corneal thickness has to be 400 microns along with the cornea, along with the epithelium.
Along with the epithelium.
So it depends. If it is the 1 or 2 cylinders, it can be done. So it will ablate around 15 to 20 microns. So there we can do a PRK extra. But if it suppose the refractive error is 3 or more, so this may not be safe.
So for the Athens protocol and all, in Athens protocol and all, you can ablate, you can correct half of the refractive error. So that
can be done. That can be done. So sometimes what some surgeons they don't correct the refractive error. They just regularize the cornea.
And the higher order aberrations, right?
Later you give a contact lens or spectacle, depending on what acceptance.
So what you're saying is for extra procedures, 50 microns of ablation is the maximum we can do.
Yeah, 50 is the safest, but nowadays they are going up to 70, 80 also they are ablating. But
Okay.
there have not been any studies where it is totally validated. It is
Okay.
not totally validated.
Okay.
Still, but I prefer to do only 50 microns. I don't go beyond. Some people they are doing even 100 microns because it looks very easy, very advantageous to patient now. We don't know what will happen later after 2 years, 3 years. We don't know
Okay.
what will happen. But 50 microns is it has been validated
Safe.
and many surgeons are doing and results are also good and it has got a long follow up also.
Sir, I have one more doubt. For extra procedure, is there any role for hypersmolar riboflavin to increase the thickness if it is below 400? Do you
Yeah.
have any experience with that?
Yes.
For
Yes.
the extra procedure.
Yes. Because it's a
Extra
thin.
also you can do.
Yes. Because it's a thin. You can do it.
Okay. And so one more question. Why is it contraindicated in lactating mothers?
Contact lens.
No, why is it contraindicated in lactating mothers? Pregnancy I can understand, but why contraindication in lactating mothers? Because I recently, CXL, contraindication in lactating mothers.
Contraindication. Because there will be hormonal changes in the mother. So these estrogens levels and all known to cause modulate the cornea temporarily, not permanently. During the lactation and during the pregnancy, there can be change in the corneal contour.
Okay.
So if you so whatever assessment we do, it's a wrong thing. So you have to wait for the in the pregnancy as well as the lactation.
Lactation, how many months, sir?
6 months we
6
wait.
months.
6
After
months.
6 months, it's
Yeah,
safe to
6
do.
months it is better. But what I do, I ask the mother whether they have stopped lactating or not. Because we cannot say 6 months, we cannot standardize for everybody.
Okay.
So the hormones, you cannot say that after 6 months hormones will be normal after 6 months. So I do whether when they stop feeding.
Okay, recently I had a patient who's lactating 9-month-old baby with
Okay.
advanced keratoconus.
Okay.
So should I wait or should I do C3R for
See,
that
this is
baby?
a very difficult clinical situation we find because they come in those period only. What would have happened is during this pregnancy and their keratoconus would have progressed very fast because they don't
Okay.
come in early phases because the keratoconus is not affecting much to their vision. And during pregnancy, because of change in this hormone, the keratoconus would have progressed. So we have to wait. There is no other way.
Okay. So once she stops lactation, like how long do you have to wait to reassess before deciding?
No, whenever they stop feeding, I'll do. Usually, they nowadays they feed around 8 months, 1 year, maximum 1 year. So
No,
after
she
one,
wants to continue till
yeah,
2 years. That is the problem. This patient I had. Okay, so after 2 years, if she stops lactating, and then you can
yeah, you can do
reassess.
it. You can choose your protocol depending on the thickness.
Okay. Thank you, sir.
I just want to make a quick comment in this regard. So basically, CXL, the studies performed earlier were never based, any pregnant or lactating mothers were always excluded from the study. So any procedure, what we are going to do is has got some benefits and risks. Benefits we are aware about it, but risk we are not aware. So therefore, actually, there is no per se why it is contraindicated, but definitely we don't know what are the risks involved in that, and therefore it's a contraindication. So it is all, we have to always weigh up benefits and risk before proceeding anything for that.
Thank you, sir.
Just a quick comment I want to make. Whenever you plan for a C3R, after starting the machine, always calibrate the machine. So because it comes with a small calibrator, and you have to check that it is giving a proper power which is intended. Suppose you set the machine on 3 milliwatt per 3 milliwatt, and at particular distance it's emitting the same amount of power. That is very important before starting C3 on a patient. So every time when you start a machine, do calibrate the machine before starting it.
So that's a very important point he pointed out. Every session you have to calibrate the C3R machine because most of us we use our Indian machines and I'm sorry to say that sometimes they won't work because they sometimes deliver more energy, sometimes they deliver less energy. So you have to calibrate and do. Yes.
Sir, have you noticed more sterile infiltrates and accelerated cross-linking compared to Any kind of sterile infiltrates have you noticed more so in
definitely.
accelerated?
See, sterile infiltrates have been, yeah, we have noticed those things, and one of the most common risk factor is untreated ocular surface allergy. So the patients who have got, the active VKC or atopy, these kind of patients do have a risk for developing sterile infiltrates. So definitely, we need to treat therefore surface allergy first and then proceed for a C3R rather than going directly for C3R.
So one more. For extra procedure, what is the time of pre-soaking and what's the power and time that you do for extra procedure? Pre-soaking time
Extra procedure depends on refractive error.
or
So
trans PRK with extra with CXL.
PRK with extra you're telling?
Yeah.
So the aim is we cannot ablate more than 50 microns. So whatever refractive error is there, either it is a cylinder or spherical, that has to fit into 50 microns.
The pre-soaking with riboflavin, when I was asking, sir. Pre-soaking with riboflavin, how long should we soak with riboflavin before starting the UV radiation?
In a
In
standard
the extra procedure. With the trans PRK, if I am doing C3R, what is the pre-soaking time? Because we've already, like ablated the Bowmans. So you don't need like,
no, see when you deepithelize in extra procedure you are telling.
yeah, extra procedure. How long should we put riboflavin and wait before starting the
See,
UV?
you can use the Dresden protocol as well as you. I'm sorry. You see. It is regularly. So every 10 minutes for 30 minutes before going inside, and inside when you are doing a C3R every 5 minutes. It is not exactly every 5 minutes. You have to see the intensity of the light.
Okay.
The intensity of the light. So it will be very bright when exact the irradiation is coming. So what happens if you see the intensity of the light is little bit decreasing, that means the riboflavin is not there on the cornea. So even though the UVA is coming down, the riboflavin is not there. That time again you have to put it. So that's why they have made it every 5 minutes one drop. And also you have to cover something surrounding the limbus so that riboflavin will not soak out, and also it will cover the epithelium. Limbal stem cells.
Okay.
Hello, sir. I have one patient. I noticed progression after 4 months of C3R. How to go about next?
See, there are some reports like that. See, there are two things are there. One is whether the progression. Things we can blame is whether we have done a C3R in a correct manner. One thing. Second thing, the innate nature of that cornea. The innate nature of that cornea is not accepting the C3Rs. So there is the whatever the weakness of the cornea is there, it is too much. That two things we can think of. So see, if you have done a C3R in a following the standard protocol, whichever you have done, Dresden or accelerated, if still there is a progression, that means the cornea is, there is an innate problem in the cornea. So these corneas, even if you do re-C3R, they are not going to benefit. So you have to think of some other procedure.
Okay. So scleral contact lens, can we?
Scleral contact lens?
Yes, sir. To prevent.
So scleral contact lens can be given. There is no, because for visual rehabilitation we can give RGP lenses and all scleral contact lenses. The basic thing is the C3R has to be stabilized.
So repeat C3R is
no. Many reports are there. Once the C3R fails, usually the repeat C3R doesn't work.
Okay. Thank you.
Just wanted to know what was the age of that patient?
27, sir.
27.
Yes.
That's quite. I think that you should go for the protocol. What protocol was used? Was it a EP protocol or was it
EP off.
EP off?
Yes.
Okay. So that's quite rare. By the way, failure of C3R we can determine only at the end of 1 year. So it's too early to catch on. Like at what basis you are saying that it's progressed? Being a Paki or like what are the
Being in Paki and K-Max also, sir.
KMAX has
But patient vision-wise and all, he is not telling anything.
You are telling Paki is reduced.
Yes, sir.
Topography?
Topography, Paki is reduced and K-Max is also increased.
Actually, this is a natural phenomenon. If there is only Paki is reduced, that is a natural phenomenon. What happens? These corneal collagens become more compact. More compact, and naturally the corneal thickness will reduce for at least for 2 years. The studies have shown
Okay, sir.
that after the C3R, the corneal thickness will reduce. Slowly it will regain to the, it is preoperative level after 2 years.
Okay, sir.
So you have done some studies also, it also shows like that. Okay, and if it is,
K-Max was also increased, sir.
huh?
Around K-Max was increased around
K-max
1.
is also increased.
Yes,
Okay. And I think you have to wait for some more time.
somewhat.
Really you have to confirm it whether it is progression or
Yes.
just it is a post of corneal, reduced corneal thickness.
Okay, sir.
See, that's why I mentioned in my presentation also that you need to take care of two things. One thing is, like I said, if they are using contact lenses after the cross-linking, because sometimes warpage can also cause that. Okay. The second thing is what happens in this very advanced keratoconus is there can be a hyperplasia also of the epithelium. So epithelial mapping is very, very important. So following the cross-linking, when you look at the progression, the first thing you need to do is epithelial mapping.
Okay, sir.
Because pseudo progression is very common in very, very high K values. So you need to ensure that, and then you do the cross linking, because
Okay,
pseudo progression is very, very common. So that is something that you also need to keep in mind.
Okay, sir. Thank you, sir.
thank you all for being with us. Thank you.